And thank you everyone for being here tonight. It really means a lot to us, and it means a lot to me. Okay. Hi. Have you been wondering what physician mental health has to do with the transformation of healthcare? My name is Gabe Charbonneau, and I'm a rural family physician and co-founder of Medicine Forward. We've changed our name from Osler's Alliance to be more inclusive, and we're excited to get to work advocating for a better future for all of us. 400 physicians die by suicide each year. It's an alarming statistic, and double the rate of the general population. Tonight, we're going to talk about things that we can do right now to start to turn the tide on this epidemic. We're going to talk about empowering you to change what's broken in our broken healthcare system. Dr. Lorna Breen was an emergency medicine physician whose death by suicide was a tragedy. My only hope is that we can learn something from what she went through. May we honor her life and the lives of other healers who have died. May we knock down barriers to having a healthy and supported physician workforce, a workforce who can care for our patients with deep compassion and empathy, but without losing ourselves in doing it. I hope you will join us on our quest. It's a quest for a world where healthcare works better for everyone. Tonight, we start with standing up for the mental health of physicians, and this is just the beginning. We imagine a world where everyone has access to the care that they need and the gift of enough time with their doctor. In this world, real human relationships are valued alongside the best care that modern science has to offer. Please join me in giving a warm welcome for our amazing moderator, Dr. Emily Silverman. Dr. Silverman is an internist at the Zuckerberg San Francisco General Hospital. She's assistant professor of medicine at UCSF and creator and host of The Nocturnists, a medical storytelling live show and podcast. Her writing has been supported by a McDowell Fellowship and published in the New York Times, JAMA, the Virginia Quarterly Review, and McSweeney's. She lives in San Francisco. It is my great honor to turn the stage over to my dear friend, Dr. Emily Silverman, to introduce you to tonight's event and our speakers. Thank you very much.
Thank you, Gabe, for that introduction, and thank you to everybody who is here this evening. This is such an important topic, and I couldn't be more excited to chat with our panelists. So as Gabe said, my name is Emily. I'm a doctor in San Francisco, and I'm the host of The Nocturnists, which is a medical storytelling organization. And I have been really passionate about taking care of the hearts, minds, and souls of physicians and other healthcare workers through storytelling over the last few years. And as we all know, the problem of physician burnout and physician depression were a big problem before COVID. And now that COVID is here, certainly we're seeing increased rates of distress among the American healthcare workforce. So now is a great time to talk about this topic. Our hearts break for Lorna Breen and her family. Thank you, Corey, for being here. And I just wanted to briefly introduce the panel because I have been working with some of these folks over the last few weeks, and I have to say I'm incredibly impressed by their tenacity, by their passion, by the work that they have done on this topic. So first, I want to introduce Dr. Kim Templeton, who's a professor of orthopedic surgery at the University of Kansas Medical Center in Kansas City. She's interested in sex and gender medicine, medical education, has served on numerous committees and advisory boards, including as president of the American Medical Women's Association, and has catalyzed some really important changes in Kansas, the state of Kansas's medical licensing process as a current board member of AMWA and past president. Next, we have Dr. Lois Swisher, who's a nocturnist at Mercy Fitzgerald Hospital, which is an inner city community hospital associated with the Drexel Emergency Medicine Residency Program. Her life story is incredibly moving and includes the story of her daughter, who was diagnosed with a malignant brain tumor, underwent surgery for that, which unfortunately left her neurologically devastated, and prompted Lois's journey in navigating the American healthcare system, being a caregiver, and dealing with some of her own mental health issues. When her child became an adult, Dr. Swisher returned to her career in academic emergency medicine with a special focus on well-being and a goal of reducing the number of suicides in medicine to 0. And she has been a pivotal member of the AMWA team on working around issues of medical licensing. Next, we have Corey Feist. Corey is a healthcare executive with 20 years of experience, currently serving as the CEO of the University of Virginia Physicians Group, which is comprised of over 1,000 physicians and advanced practice providers. He has a bachelor's from Hamilton, a JD from Penn State Dickinson School of Law, an MBA from the UVA Darden School of Business. And he's also the brother-in-law of Dr. Lorna Breen, who died by suicide in 2020 during the COVID-19 pandemic, which prompted his co-founding of the Dr. Lorna Breen Heroes Foundation, which has already accomplished an enormous amount, including some important legislation that I'm excited to talk about later in the hour. Last but not least, I'm thrilled to introduce Dr. Brian Dixon, who is a board-certified child and adolescent psychiatrist and owner of Mindful, a therapy-based psychiatric practice in Fort Worth, Texas. Brian believes in maximal empowerment, minimal medications, and psychoeducation, and Dr. Dixon supports adults, kids, and families as they work to improve their mental health. And he has also worked specifically with physicians around their mental health. So I know that was a lot of information, but I just wanted to say thank you so much to all of our panelists for being here. Just going to give you a little round of applause. All right, so let's just dive right in. The first question I wanted to throw to you, Lois. Before we get into some of the problem-solving aspects of this, I wanted to take a minute just to define the problem a bit more specifically. So we talk a lot about physician burnout, and we also talk a lot about physician depression. And I think it's really important that we clarify and define these terms because there is some overlap there, but they are also different entities. So do you mind just taking a minute or two to explain to us how to think about burnout and depression and similarities and differences?
Sorry about that, I was muted. Thank you so much to Medicine Forward for inviting me here. And I am really glad you brought this question, Emily, as one of the first things, because the words sort of are muddied in the literature, and how we define them individually may not be the same from person to person. The way I think of burnout started in the 1970s, and it was related to the job and had three components: an exhaustion, physical, mental, spiritual exhaustion in the job. There was a cynicism. Some people feel detached from their meaning and their workplace. And then this feeling of low satisfaction, that they really aren't getting personally what they were wanting out of their job. So burnout has everything to do with the career. Whereas I see depression being your life. It is something that affects every part of you. There is a sadness and a hopelessness of just making it through day to day. Now, there may be low self-interest in both, but that hopelessness and sadness that comes with depression is all consuming. They may overlap, that's true. Somebody can both have burnout and depression. And there's a lot of other factors that affect physicians' mental health, specifically because of their job, that don't really fit neatly into each of those categories. For example, litigation stress syndrome, malpractice is a huge impact on mental health. There's compassion fatigue, just by being a healthcare worker on the front line, seeing one after another person that is suffering, that there's a hardening of the heart. Second victim syndrome, when you've made a mistake or you think you make a mistake. These all play into mental health. And so there are other things to consider between burnout and depression.
Thank you, Lois. I think that's really helpful also to think about the other stressors that we face beyond just burnout and depression. And I think you really taught me that burnout is an occupational stress syndrome and that depression is a medical illness, and that while people may have some overlap, that they are different. So thank you for clarifying that. And so, you know, physicians are at risk, right, of suffering from all of these different types of distress conditions. And yet the reality is that physicians don't seek mental health care. Some people decline to seek it altogether. Other people delay seeking mental health care. And of course, you know, this is not a rule. There are plenty of people out there who do seek mental health care, but the broader trend is that physicians, there are just a lot of barriers to getting healthcare. And I just wanted to cite a survey that was done by Medscape in 2021. And the top reasons for physicians not seeking mental health care were: 1, the symptoms aren't bad enough; 2, I can deal without help, I don't need help, professional help; 3, I'm too busy; and 4, I don't want to risk disclosure. So I thought that survey was really interesting. I think the first 3 have a lot to do with the physician psyche and the physician culture and the way institutions work. And I want to get to that toward the end, especially Brian. I'd love to chat with you about that toward the end of the hour. But I want to spend the first couple chunks of the hour really honing in on number 4. So number 4 is, I don't want to risk disclosure. And this is a huge issue. And so I'm going to toss this one out to Kim and Lois. Maybe Kim, you want to start. When physicians say they don't want to risk disclosure, what does this mean? Who are they disclosing it to, and what are they talking about there?
Well, that's a great question, and it's an extremely important issue. As you mentioned, the first 3 on the Medscape survey were cultural within medicine. It's part of the stigma within healthcare. Those are things that we need to address, but those are going to be much larger issues that are going to take time. When it comes to issues about disclosure, those are much more concrete areas that we can address. And even hopefully by addressing those, we can start secondarily changing the culture and the stigma. So the concern is I think primarily releasing health information, whether it's physical or mental health issues, both to your hospital in terms of credentialing applications and to your state licensing board when you're applying for licensure or when you are renewing your license. I think some of the concerns are understandable because to some degree it's a black box and they don't know what happens when they disclose. I think also a lot of docs have heard horror stories about what's happened if someone is disclosed. I don't know the details of a lot of those stories, but when you look at them from the outside, you have to think that there's something else going on. As a state medical board member for well over a decade, I don't see someone losing their license solely because they've admitted to having a mental or physical health diagnosis. That always perks up my ears that there's must have been something else that was going on. But yet those stories are out there. And when you don't know what happens and you hear those stories, that at least gives you some information, even though it's not good information. But I think it colors your intentions and it makes you concerned about admitting to those diagnoses and wondering what happens. Now, when you look at the history of those questions, those were not put on applications because of any sort of nefarious intent. The thought was that if state licensing agencies or hospital credentialing boards asked about physical or mental health diagnoses, that was a way to help protect the public and patients, which are the missions of both organizations, and that somehow by asking those questions, they would be likely to pick up people that needed help or had issues in the past, and thus maybe at risk for having issues in the future. So although well-intentioned, what's been happening is the exact opposite. As we know that docs, if they do have a health condition, but they're afraid of admitting it or having to let someone know, a licensing agency or credentialing board, let them know about that health condition, better to not seek care so there's no documentation of that than to seek care and risk facing the unknown. And so that's where licensing boards are starting to look at this and to change licensing, because as we're finding more and more from a practical level that these questions keep docs from seeking care, you've got to wonder what the long-term impacts are on patient safety and public safety. And that is a major driver in trying to change the questions, because we know that they didn't work as intended. They could potentially be making things worse. So let's try to fix that. And that's at least something concrete we can do to try to encourage physicians to seek the help they need.
Thank you so much for that overview. I mean, what I'm hearing is that these questions are meant to protect the public, but they're actually having the opposite effect in the sense
Right.
that, these questions are scaring physicians away. And maybe Lois, for you, like, for me as a physician, I don't know what counts as like bad enough for a mental health condition for me to have to report it. And I also have no idea what will happen if I report. Can you talk a little bit about that? Like how how does that work when people are deciding whether or not to disclose or not?
Right now, I think a lot goes into the culture of medicine and what the people beside you tell you. When you started telling my story, and when my daughter became disabled after having her surgery, I felt incredibly guilty and responsible. When that happened, I started seeing my life changing and feeling that I had to do something to take care of this. And I was the one that did this to my child. My child was the one who was suffering from my faults. And so I started thinking I didn't deserve to live. And when I started mentioning that, um, my colleagues, their eyes were like deer in the headlights. And I think we teach each other by that response that you don't talk about it. And when we don't talk about it, we don't know the consequences. There's no transparency of process or what's going to happen. And you believe that if everybody else around you is staying silent, it must be something bad. And just the look in the eyes, you got the feeling, I'd rather die than disappoint you. So let me see if I can hang on to this day, I can hang on to another day, and maybe it will be okay. And it wasn't. It wasn't until I started talking about it and realized I made it such a bigger deal in my mind. I was in the lucky area because I had thoughts, but I wasn't impaired. I started unraveling this, and this is what the state medical boards are looking for. They're looking for impairment. They're not looking for illness. They're not looking for you're having a bad situation and you have to talk about it. But I think we in medicine have not caught up to that term and equate the potential of having an illness or a situation automatically being assumed that it's impairment.
Yeah, that's a great point. The difference between having a condition and impairment. And, this is what the Americans with Disabilities Act was designed to address. And Kim, maybe you can speak to the ADA, and also if I report that I have a mental health condition to the state board, what happens?
Those are great questions, and that's where the licensure is trying to mirror more what is required in the ADA, at least in some states. States are extremely variable in what they put in their licensure application or the renewal forms. They can ask nothing, which is what some states are going toward. On the other hand, they can ask, have you ever had a mental or physical health condition? Have you had a condition in the past 5 years, 2 years, 3 years? Have you had issues with addiction? Or in the intermediate, not ask about specific diagnoses, but only ask, are you currently impaired? And so where we're trying to get, and where a lot of states have changed the language to mirror the ADA, as Lois said, go from asking about a specific diagnosis to asking about, are you currently impaired? So not asking about anything in the past, not asking you, have you had a condition that might at some point impact your practice in the future, because that's extrapolating and they can't do that based on the ADA, but solely asking, are you currently impaired, yes or no? If physicians answer yes, and this is where docs get scared, I think, at times about seeking help, which I completely understand, they may be asked for a description of their past medical history, of the treatment they've received, but this is also where states are extremely variable. They may ask for that background, or they may refer someone to their state physicians or professionals health program, which is a confidential resource separate and apart from the state medical board that can work with the physician in trying to work through the various issues that they may be suffering from, and if there's any current condition with which they need help. But what's concerning on some state licensure applications, where there's still questions about asking about specific diagnoses and asking for their past medical history and descriptions of their past care, that understandably makes physicians concerned about seeking help.
And speaking for myself, I have no idea where California falls on that spectrum of stigma. And I know that many of you have been working painstakingly to create this map of the United States, where you have each state and you collect what is the language for the state medical licensing for each state. So can you maybe show us this map and walk us through it and tell us, I'm very curious, what are the best states? What are the worst states? Maybe talk a bit about the gray areas, and then what should we be aiming for?
Sure. Let me just share our map. Let's go to. So here is the map that we have been working with AMWA. And this is a draft form. We've just begun to show it to different groups. And the reason is that this is tough. There are 50 different states and the District of Columbia. All of them have their own license. And when you go back and look through other groups who have looked at the licenses, there's disagreement on what is a good state, what is a bad state. And then when we try to go back, there are portals on individual states, some individual states, so it's hard to get the licensure language. So when we started with this, we naively thought there would be good states and bad states. We would be able to do a red and a green. As we got into individual language, we realized states crafted the semantics a little differently. And so for people to understand what was going on in their state, really, they were going to have to see the language. But we could give a general overview of how the country was doing with these, with the initial MD licensure. And I want to make that clear. Osteopathic, 16 states are different. So if you're an osteopathic physician, the map may not look like this. If you're a medical trainee, if you're a resident, your license may also be different. If you are reapplying, it may be different. This is a complex area. This is for initial application in each state. So as we went through, we started looking at the states and we wanted to know the red states, those that had issues to be aware of. And this is Arkansas. Have you ever had to discontinue practice for any reason for longer than 1 month? We thought that that might be concerning because there are many reasons that you have to take off a month. But if you did that because of pregnancy, would you have to report? If you had an injury, do you have to report? This is ever in your lifetime in practice. There are questions about being monitored by a physician health committee in any state. Well, if you were in a state that you didn't have to report, you may think you don't have to report in any state. But if you go to Arkansas, if you were in one in any location, you have to report. So may not be an issue. If you were not in a physician health committee service, you may not think that this is important, and that wouldn't affect you going to Arkansas. Yellow, I picked Montana. And this one complies with the ADA in that it is current impairment, and current under the ADA can be 2 years or less. So within 6 months is considered current. And it deals with impairment instead of illness. Now, what makes a green state? No questions. Michigan, New York, Rhode Island, Connecticut have no questions. The reason why Pennsylvania, Utah, and Hawaii are in that darker green is that there are no mental health questions, but there are substance abuse questions. Pennsylvania is 2 years, Utah and Hawaii are 5. And then the most unusual state is Mississippi. Recently, they have gone from being one of the worst worded questions to having no questions, but better than that, they're trying to change culture and inform physicians that the board recognizes that we are human and we can have the same medical problems, psychiatric substance abuse problems as our patients. And they expect us as physicians to take care of our health. That is what we really want, is we want physicians, docs, to go out and take care of themselves before they have impairment. And there's the warning there, if you don't take care of yourself, then that is the risk. Not taking care of yourself is more of a risk than coming forward seeking help. And I think that this is the area we want to be. We want to get to the blue states.
Thank you so much. When I first started hearing about this, it made sense that the red states would have threatening, punitive language. Do you have, blah, blah, blah. And I thought that the gold standard would be just to get rid of those questions altogether. But something you once said to me, Lois, is having no questions at all almost fosters this kind of like culture of silence, like don't ask, don't tell. And how this, the only blue state on the map, Mississippi, is really leading the way in not just eliminating the questions, but actually supplying language that is supportive, that is encouraging, that is acknowledging of the fact that physicians are people too, and that they, encouraging them to take care of themselves. So I don't know if there's anybody in the audience who is practicing in Mississippi. If you are, I would be super curious to know if you were aware of your state's leadership in this realm, and maybe we can save that for the Q&A later.
Emily, I will make a point that North Carolina was actually the first state that did have an attestation, but it's not in the initial license. They did that in 2018, but it's in the re-app. So
got it. Yeah, so for the audience, North Carolina also has very positive, healthy, encouraging language similar to Mississippi. It's just not in the initial license, it's for the re-up. And so North Carolina maybe could still move toward Mississippi. So Mississippi and North Carolina sounds like are leading the way here. And I guess my question is, and I'm gonna just ask this one more question of Kim and Lois before I turn it over to Corey, is how do we get to blue? And Kim, I know you've had some success in Kansas. So for our audience, like looking at this map, locating themselves on this map, who are like, I want my state to get to blue, how do we do that? And how do we go forward from here?
Well, you're right. We did some work in Kansas. I had the advantage of having been on our state medical board for over a decade. And so I was there longer than any other board member or any of the other attorney staff, I think. And so that carries some gravitas with that. I also, as president of AMWA, was asked to review the paper that came from the Federation of State Medical Boards on physician burnout, in which they had recommended language for both hospital credentialing forms as well as state licensure applications. So I went to our board and brought up the issue and said, I think it's time that we change this. I also went to our hospital to ask about credentialing, and they said, well, we'll discuss it, but we want to see what the state does first. So I started off with the state medical board. And showed them what the FSMB had recommended, showed what other states had done, talked about why continuing to ask about past medical health issues was not helping us. There were too many docs going underground and not seeking help. And they agreed. And so we changed the language. We didn't go to the attestation. We did go to rather than asking, we had 5 questions before, asking about past 2 years worth of history. We now have the single yes, no question. Are you currently impaired to practice medicine? That's it. And it actually now that's for all the healthcare professions that our board regulates, which is the vast majority in Kansas. And we've also removed the stigmatizing language from the peer references. The next step is likely to actually remove those references. And we also are going to look at the application overall, and we may take the next step and go beyond. And we haven't discussed attestation, but we might. So it's reaching out to your state medical board, trying to find someone on the board, either attorney staff or board members. Do your research first, read the paper from the FSMB, know what the FSMB had recommended in terms of language, and also see what other states have done. And the map Lois has put together is amazing. You can go to that and get sample language and then start talking with your state and talking about the issues with mental health care. Remind the board that their mission is to protect the public. And you do that by making sure the docs get the care that they need.
Thank you so much. I wanted to, we are so short. I wish we could talk for 2 hours, but we have 1 hour. So I want to make sure that we get to Corey, because Corey, you're very well versed in these issues around medical licensure as well. And I know that you have also been doing some work in this area through the Lorna Breen Heroes Foundation. Tell us a little bit about the Heroes Foundation. What has it already accomplished and what is it working on?
Thanks, Emily, and thanks for having me. I think this is an incredibly important conversation, and I always learn something sitting on these panels, and I've already learned a lot. That is that Kim and Lois are the experts, so call them. So the Dr. Lorna Breen Heroes Foundation, as you stated before, we founded that. My wife Jennifer and I co-founded that this summer following the death of our dear sister and sister-in-law, Dr. Lorna Breen, on April 26, 2020. And the response that we got to her death and the publicity around her death was just this collective cry for help that we heard from across the healthcare industry. And so Jennifer and I never intended on starting a foundation, but as you heard, and you've heard from Jennifer across the media, that this has got to stop. And so what we did was we started to focus on awareness. And what we learned very quickly was that when something tragic happens to you, something unspeakably tragic in particular, and you speak about it, it gives others permission to come out of the shadows and speak about it. And so just sitting on panels like this and speaking to many, many others, Jennifer and I have now reached over 65 million people around the world with this message and this story. And we've heard from so many physicians, nurses, others who have just said to us, we've seen ourselves in this story and we're getting help. And so you never know how many people you can help, but we know that because we've heard anecdotal stories, that just talking about it and creating space for the conversation has made a big impact. So that's been our number one area is in awareness. As part of our awareness focus, we've also worked both with the American Medical Women's Association on this Humans Before Heroes initiative on state licensure, as well as at the federal level with Senator Tim Kaine. And this past summer, he introduced the Dr. Lorna Breen Healthcare Provider Protection Act, which provides both immediate and long-term solutions, or begins to address them, I would say. We worked all through the fall to try to get that passed and funded. We were unable to at the end of the year, but we're so excited that that Senator Kaine reintroduced the bill after the first of the year. And it already has $140 million in funding from the American Rescue Plan. So the big areas of funding coincide with the bill, but we still need to get the bill passed so we can get some real specific language. But first, $80 million goes to our future healthcare workforce, creating programs in healthcare professional training schools, like nursing schools, medical schools, go down the list, to learn about these issues and figure out how to not only support each other, but yourself as a future healthcare professional. $40 million goes to healthcare organizations right now to provide programs to support their healthcare professionals. I think it was really important that you started this piece by differentiating between burnout and depression and trauma, because I think that the healthcare industry needs to learn both, as Lois was saying, that there are occupational issues that drive burnout, which are different and distinct from trauma. Both result in workforces that need to be supported, but they're different and the causes are different, and we need to get upstream of those causes. And hopefully some of the $40 million will help, or the $40 million will help. In addition to that, $20 million goes to a national awareness campaign on these issues. One of the things that we've learned in many, many talks and listening to other healthcare professionals and in the industry is that many organizations don't realize that they hold the keys to solving these issues. They don't understand the impact of burnout on the patient care. We know that there's a 200% increase in medical errors when our healthcare professionals are burnt out. How many hospitals across this country understand that? And how many of them understand really how to solve those issues? So that's been a big awareness focus. We've also now transitioned to helping to be an advisor to the healthcare industry. Over the past year, we have developed contacts and across the entire the professional landscape with experts in many, many fields who can provide solutions. And we'll be launching in April an all-in campaign for every hospital in this country to sign on to the well-being of their workforce. And then finally, we intend, and we have developed funds to fund some of these programs ourselves. So we've been busy, Emily. And as Jennifer has said many times, we're just getting started. This is our passion, and this is our life's work now. And really, really a pleasure to be here today.
Thank you so much, Corey. It's really heartening to hear that $140 million has already been dedicated to this purpose. And we look forward to hearing about the programs that come out of that. And I imagine there will be more questions about that in the Q&A. But before we pivot to the Q&A, I did want to ask you a few things, Brian. We talked a lot about disclosure, and we definitely got in the weeds a bit around each different state and the map and the licensing. But I did want to talk about responses numbers 1, 2, and 3 from the Medscape survey. So this idea that my symptoms aren't that bad, I don't need help, I'm too busy. Like, even if we were able to change the state license rules in all 50 states, there's still this water that we're swimming in, this medical culture. So as a psychiatrist who is a physician and who has worked with physicians around this issue, what have you noticed about the individual physician psyche, but also just like medical culture as a whole in causing barriers to people seeking help?
Yeah, so we go into medicine as a competition, right? So you go through pre-med, you go through medical school, you're doing your best to make the best GPA and board scores and that sort of thing. And so that in and of itself can be very isolating. And so by the time you become an attending, and you're still running, right? You're still running to get RVUs, trying to get the best job, trying to build, work out all these contracts. It can be so overwhelming and so lonely that it just perpetuates burnout. And so kind of letting your hair down, being able to say, you know what, I'm only one person. I can only do what I can do. Hopefully having supportive staff and colleagues. I think that's one of the best ways to head off the social isolation. And it also helps that we're having all these movements about equity and equality and inclusion. So those are a great help.
Thank you so much, Brian. And there's something that I saw on your website that I loved, where you said healthcare workers can save ourselves from ourselves. So tell me a little bit about that. What does that mean and how does that work?
Yeah, so first off, y'all, I have the best job in the world. I love being a psychiatrist, and I get to help people feel better. And I think that that's just amazing. And so one thing that I tell all of my patients, including my physician patients, is that you are a terrible therapist for yourself. And same thing goes for parents and kids. You're a terrible therapist for your kids because you're too close to yourself to be objective. It's really, really hard to do that. And so, yeah, so as healthcare workers, we are terrible healthcare workers for ourselves. And so getting other people involved is super helpful. Not only can we, as trained mental health clinicians, we can see we know typical adult development, we know typical childhood development, we understand dynamics. That's really hard to see when you're in it. And so, yeah, so I encourage every healthcare worker, just like every patient, to have a therapist. Every single person should have a therapist, so you can talk it out. It does not hurt to talk about your feelings and to be proactive about it. That's my other big pet peeve. We're very reactive, and we tend to wait. And I don't want people to wait anymore. I lost a friend to suicide in my intern year, and I don't want to see that again. So yes, be proactive.
Yeah, what you're saying really strikes a chord with me. I just notice in myself and also in a lot of my friends and colleagues, we are very, very cruel to ourselves. And I have voices in my head that are talking to myself, and they are not nice voices. And somebody mentioned this tool around measuring levels of self-judgment and self-compassion. So how do we create more self-compassion, and how do we tone down the judgment a bit? And this is, if we could figure this out overnight, we would make many strides. But I think just starting with acknowledging the fact that we're hard on ourselves and going forward from there is a great point. So thank you so much for saying that. Yeah. We're just about to hit the 40-minute mark. So I wanted to invite Gabe to share a slide that he created. That's a call to action. So, we as a group thought a lot about, for those in the audience, what are things that you can do today to help with this topic? And so what we came up with is first, ask yourself and your colleagues, how are you? No, but really, how are you? And invite people to be honest about how they're doing and increase compassion for yourself and for each other. Second, we talked about the power of leading with vulnerability and sharing your own struggles. Obviously, nobody is obligated to share anything that they don't want to, but if you do choose to share, sometimes that can have incredible ripples and inspire people in all different generations of healthcare to feel less alone. And it really just normalizes the fact that we're human beings who suffer from a variety of different mental health conditions. We talked about advocating to change the licensing questions in your state. I think, we should just get that all taken care of and make sure all those 50 states are where they need to be. That is like the bare minimum and the starting line. I wanted to mention that the Nocturnist, which is the medical storytelling organization that I run, recently launched a call for voices on the topic of shame in medicine, which is deeply connected to this topic of physician mental health. So if you're interested in telling your shame story anonymously or not anonymously, and submitting that to the Nocturnist for consideration to be featured on the podcast series, please check out thenocturnist.com. There's a lot of information there. And our hope as the Nocturnist is that this audio documentary storytelling project will lift the lid on shame, because just by doing that, you do change the culture. And then lastly, of course, if you wanted to become a member of Medicine Forward, we'll have future discussions in town halls just like this, where we can talk about all of these issues. And then I see a note in the chat from Kim that says, don't judge how you're doing because you're not worse than those you see around you. Remember, a lot of them are burned out and not doing well either. I couldn't agree with that more. So we're going to turn it over to the Q&A portion of the evening. Tatiana, do we have any questions from the audience? Looks like no questions so far. We have a quiet audience. I'll start with a question. My first question is, I guess I'll throw it out to the group, but maybe especially you, Corey. Before COVID, the problem of physician burnout and depression was starting to become on the radar of different hospitals and institutions. And, we talked a lot about like going from the triple aim to the quadruple aim. So adding in the provider well-being, and a lot of institutions started launching things like wellness committees and really wanting to do things to improve the mental well-being of the workforce. But a lot of these efforts just don't work and fall flat. For example, people will offer like yoga, ice cream socials, mindfulness resources, resilience workshops, and a lot of these offerings are actually met with disdain by the healthcare workforce, who feel like they're being grinded into the ground by these powerful institutions. And then the powerful institutions are talking about yoga when what they really need is a better work-life environment. So I guess my question to you, and also to the group, if anyone else has thoughts, is if we're going to be funding hospital-based programs or institution-based programs, how do we make sure that we're not just feeding money into a system that's already not working so well?
So there's an excellent question, Emily. And one of the things that's really important about what you said is that, as I was saying earlier, the solutions here, I don't believe, are well known to hospitals and health systems right now, which is part of the work that we're launching with in April through the Lorna Breen Foundation, in collaboration with the American Medical Association, the American Hospital Association, the Association of American Medical Colleges, the Schwartz Center for Compassionate Care. The list goes on, the American Nursing Association. The list goes on and on, because many of these organizations have actually done research and figured it out. Let me point out one thing, and then I'd love to hand this over to the rest of the panel. There, a few years ago, Harvard T.H. Chan School of Public Health led a survey of what the root cause of burnout was in this country for physicians. And the biggest driver for burnout is the electronic medical record. Said more probably generally, bureaucracy that gets in between a clinician and their patient is really a trouble. What I think is really important about any program is that we look at both things. First of all, we need to figure out how we can support our workforce right now. And right now, the workforce is traumatized and is burnt out. So they're going to need things to just almost stabilize. We're treating symptoms here. But what we really do is we need to go upstream and treat cause. And if, for example, electronic medical record vendors have tools at their disposal to make that a more facile tool, which all of them now do, how many hospitals across this country are actually utilizing them? How many of them are looking to see, as an example, how Dr. Swisher's out before and after work time in the electronic medical records compares to her peers? And if she's an outlier, how many of our hospitals are saying, hey, Dr. Swisher, there's an hour-long training here, and we're going to tailor the electronic medical record to you? How many of them are doing it? All those tools are now at the disposal of these health systems, which own these very, very expensive electronic medical records. And so that's one very concrete thing that can be done. And through my work at the University of Virginia, we have sponsored a number of initiatives tailored at making the electronic medical record a more user-friendly tool to the clinicians. It was designed for the patients, not to be optimized by the clinicians, and that needs to flip on its head. And so that, if we just did that one thing, it would be huge. But there are many others. The American Medical Association years ago came out with a program called the Joy in Medicine program, and it outlines 6 concrete things that organizations can do. And importantly, only one of them is providing those, providing the programs to treat the symptom. They're all about getting upstream of these issues, looking at policies, looking at practices that to eliminate the what I would use in the term of lean management theory, waste between a doctor and her patient, if you will. So that's probably a broad answer, but those are some concrete things that absolutely need to happen. And the tools are out there. Many of these organizations I listed have publicly available toolkits for hospitals to utilize. It's and the last thing I would say, and you alluded to it, but it's the most important thing, is that the leadership at the hospitals and health systems have got to own this. They've got to recognize that this is it's not theirs exclusively, but if they don't lean in and make a top-down, bottom-up, approach to this, nothing will get done. So there's got to be a commitment of resources and just a commitment to the well-being of the workforce. Last comment on this, Southwest Airlines made this commitment years ago. I used to study them in business school. Their whole approach was, if we take care of our workforce, they will take care of our customer each time. I think that has been missed in healthcare. We talk so much about the patients who are our customers, but we forget about those who are taking care of them. And now more than ever, we've got to step in and take care of them.
Thank you, Corey. I have another question from the audience, or our first question from the audience, rather. How do you know if you're impaired? So let's say you're burned out or you're depressed or something else, and you're asked, are you currently impaired? How do you know if you're impaired or not?
I'll give that to Lois.
No, it's a great question. And there is language in the Federation of State Medical Boards on impairment. But this is where a problem happens with physicians, is that when you get to that level and you want to ask the question, then you feel like you're getting a target on your back. But generally, it is whether you're able to safely practice medicine, whether that is a physical issue, a psychiatric issue, a substance abuse issue, and that can be hard to determine until you get far down and are making mistakes, causing harm to patients. I think the Federation of State Medical Boards is updating that guidance document as we speak, and should be coming out later this spring with a new guidance document.
Kim, I think you're on mute.
Okay, how is that better? Okay, good. I just didn't know it was on mute. I'm sorry. I also wouldn't leave it to the physician to make that determination if they're impaired. If they have a mental or physical health condition, if they have a substance misuse problem, Ideally, they're seeking care, and I would defer to their healthcare professional to help them define whether or not they're impaired. And that's really what we want to do when we're changing this language from diagnoses to impairment, is to use that as an encouragement for docs to take a step back. If they're not seeking care, get the care they need, make sure they're not impaired, and then apply at that point. So I wouldn't rely, if you have a health condition, I wouldn't make that determination on your own. Seek care, get the care you need, work with your healthcare professional. And if they think you're impaired, then you need to take a step back. And if you're not, then answer no to those questions.
Yeah, and I would throw out to y'all as a treating psychiatrist that we don't think in those particular terms. So whoever shows up in my office is who shows up in my office, and I'm going to take care of them. So whether or not you may or may not think you're impaired, if you come in, it's my job and my role to assess you like I would anybody else. And then if there are specific recommendations I need to make, we will do what is in the best interest of you as the person. And then later on, we can figure out all the work stuff if you want to do that. But the first thing, our first goal is to help you feel better.
Great, thank you. There's another question for Corey here about the legislation. So I know that in the COVID relief bill, there was $140 million allocated to this, but then there's the Lorna Breen Healthcare Provider Protection Act. So people are asking, what is the difference between those two things? How does the act strengthen what's already been passed?
Yeah, great question. We did this backwards because we had an opportunity to get money. You usually don't get an opportunity to get money before you have a bill passed, which is actually what happened here because it's COVID times, right, people? Everything is just backwards. The Dr. Lorna Breen Healthcare Provider Protection Act has the very specific language about how the programs need to be deployed, what the real intent is behind the law. Right now, the $140 million is really very general budget language that talks a little too generally, frankly. So we need to get the act passed so that it gives the concrete direction to Health and Human Services on how to administer the program. In addition, the one thing that didn't get funded in the budget bill, but which we're hoping to get funded by passing the act, is a study provision which will allow us to really understand at a national level whether these interventions that we're funding are having an impact and what that impact, positive or negative. I'm sure there will be positive, but I think that the important thing here is we still need to get the act passed, because absent the act, HHS won't have the specificity that we really want to administer the programs in the way that the industry experts who developed the Lorna Breen Act desired. But again, it was a little backwards. We don't usually have that in the world. I'm not a federal legislative expert. I've never done law before like this, never created it, but it was a little backwards, but we have the money already. And if for some reason the act didn't pass, we would still have the money and just have to work closer with HHS to try to get them to do it. But we have every indication that the act will pass. And to those who are interested in more information, I'll just direct you to our website, drlornabreen.org, and you can actually click on a take action section there and send a letter, an automatically generated email, letter, or tweet, whatever you want, to your legislator in your state and have them support the act. So we're really excited about it. Hope it'll get passed in the next 60 to 90 days.
Thank you, Corey. I have a comment here from Roberta, who's recommending to everyone listening to please have good disability insurance because it can be life-saving. It should have own occupation coverage so that doctors who cannot practice have coverage, even if they are not completely disabled and unable to work in any capacity whatsoever. And this conversation around disability insurance is reminding me of some of the conversations I've had with you all around how there's the state medical board, but even if we get all those states to blue, there's hospital credentialing, there's insurance, there's disability. So is this just the problem that will never be solved, or how do we kind of tackle all of those things? And maybe any comments specifically on disability insurance, since Roberta brought that up.
I can start unless anybody. So I think you're absolutely right on the disability insurance. You need to make sure you've got it. It is critical. As a lawyer, I can tell you that having disability insurance, make sure you understand what your policy is, and make sure you understand if you're employed, what your institution has, versus what that supplemental policy you might buy is. I want to make a point, Emily, to your comment on credentialing, because I was waiting for this moment, if you will, but I think it's important also for the audience to understand. In May of last year, the Joint Commission that accredits healthcare institutions came out with a very strong statement, because there was a lot of, in the wake of my sister-in-law's passing, and there was a lot of conversation around this issue of licensure and the questions. And I just want to read from a May 12th statement that was issued to all hospitals and health systems, and this would guide the credentialing. It says, the Joint Commission does not require organizations to ask about a clinician's history of mental health condition or treatment. We strongly encourage organizations to not ask about past history of mental health conditions or treatment. As an alternative, we support the recommendations of the Federation of State Medical Boards and the American Medical Association to limit conditions that currently impair the clinician's ability to perform their job. And it goes on and on. But I did want the audience to be aware, if you're working in an organization that asks these questions, direct the credentialing office to that statement, which is publicly available. We can put a link in the chat if people can get to the chat. I can do that now. But those questions are not mandated by the Joint Commission. And as many of you know, hospitals tend to look to the Joint Commission as to what is in their credentialing forms and what is in their medical staff bylaws. And so it is that the Joint Commission wanted to make it abundantly clear that it was not their requirement. Now that needs to go the next step, which is if, who's making this requirement, and if it's the local institution, one would comment on, as Kim did earlier, about current impairment going to the Federation of State Medical Boards as guidance there. I don't know if Kim, you had anything you wanted to add to that.
No, I totally agree. But when you go to your hospital credentialing, what you'll usually find is that they're asking the questions for the same reason. They think that the patients expected them to ask those questions. Once you can get past that barrier, though, I think they're still going to say, well, what is our state licensure board doing? So if you're in a state that's in the yellow, blue, or green category on our map, then you can probably work with your hospital in having them change the language to something mirror the state licensure language. If you're in a state that's still red, you're likely not going to be able to get credentialing language changed until your licensure application changes, because that helps to be a driver for them. Because I think they think the assumption is, if the medical board doesn't think it's worth changing, then why are we wading into these waters?
Yeah, it's good to hear about that order of operations. And that's what happened to you, right, Kim, is you actually started at the level of your hospital and they said, go change it at the state level. And once that's done, come back and talk to us. And
which we did. And now we're working on changing it.
Great. Here's another question. Doctors feel guilt about needing time away from our patients, especially if they're in small practices. The message seems to be that doctors feel shame for needing care themselves. Care is something they give others. It's not something they need themselves. Sounds like maybe a comment more than a question, but yeah, I guess I'm thinking about the one that haunts me, to be honest, on that survey of why don't you seek care is the one that says too busy. Because even if we could change all of the rules and regulations, and even if we could, shift the medical culture, if we're, charting in bed at 9 p.m. and working 80 to 100-hour weeks, there's not going to be the space for care. So I don't know, any comments here about like the shame around needing time away, and really zooming in on that word time. And it's something Medicine Forward is really focused on.
Well, I think one thing, just remember, every time you get on an airplane, they tell you to put on your oxygen mask before you help somebody else. Healthcare is the same way. Unless we take care of ourselves, we cannot take care of patients. So as I typed in the chat, self-care is not in conflict with altruism. If we truly want to take good care of our patients, we need to care for ourselves first, and you need to figure out a way to carve out time.
And mental health therapy is not easy. If it was as easy as taking a pill, everybody would do it, right? And so doing the work of figuring out who you are and how you connect and relate to people, it's hard. So yeah, I put in the chat, busyness is a defense mechanism, just like denial. Oh, well, I don't have time. Oh, I'll get to it later. Well, there is no later. It will only get worse unless you address it.
Yeah, and I just want to add, like, if every physician in America went to their boss tomorrow and said, I need an hour a week for therapy, the healthcare system would collapse. So like, how, if we all
Maybe it
just wake up,
should.
if we all wake up one day and decide that we need this, like the system's change is going to have to follow. But I think being able to speak up for ourselves and what we need is really important. I see that Gabe has come back on the call. So thank you so much for this really just rich conversation, very dense hour, but incredibly informative, and I hope inspiring to our audience. And I will turn it back over to Gabe. Thank you, Gabe.
Thank you, Emily, and thank you everyone who joined us tonight. This was so meaningful to me, and I think to so many of us right now. And let us learn something from what happened with your sister-in-law, Corey. I really think we need to do that. We need to not let this go away. We need to do better. It's important to us. It's important to future generations of physicians. Lois, when you sort of winked about Montana, I'm in. I'm going to advocate in my state to help do the best that I can. And I challenge everyone who's watching this to think about your state and how you can do something, because we've been complaining that we have learned helplessness, that we can't change the system, that we're stuck. And this is a chance to change things for the better. And that's a huge part of why this organization was created. We want to make medicine better and have a better future for everyone. We want to restore the doctor-patient relationship. And I'm just so grateful for everyone who's been on this call, and look forward to hearing more from you. Please get in touch with AMWA. Lois and Kim have put together some amazing resources, and please also follow along with the Lorna Breen Foundation. I did fill out the form and contact my senators. So please, everyone, do that as well. This is, things happen if we do things. So this is on all of us. Let's do it. And thank you so much.
Thank you.
Thanks, everyone.
Okay. Good night.
Good night.